I would now like to welcome Dr. Sagar Bhargav, who is a consultant at PBI Foundation, Kolkata, and is director in SLR Eye and Retina Surgeons Private Limited, Kolkata. He completed his MBBS and MS from Aurangabad. He had to his credit a lot of awards. He got the Dr. Pandit Palitkar Memorial Prize for standing first in MBBS, Dr. Bal Chandra Mukund Memorial Prize for standing first in subject of ophthalmology in third MBBS. He has received the R. Balachandran Memorial Prize for securing highest marks in MS ophthalmology. While working in Shankar College, he was recognized as the best associate consultant in the year 2008. He was conferred upon the Dr. T.L.K. Employment Award. In the year 2008, after successfully clearing examination, he was conferred the Smart He also started LASIK Center Shankar College in 2011. He was the first
Great. So, good evening, everybody. At the outset, let me thank Dr. Manish for this invite, and I really want to commend Dr. Satyajit Sinha and really applaud him for the humongous effort that he has undertaken for last almost a month, conducting this webinar for the postgraduates. Really, it's a great effort on his part. So, I'll be speaking about normal tension glaucoma, and when we talk about postgraduates, I understand that any topic for postgraduates is important if it has a potential to be asked in exams, and I believe normal tension glaucoma is one of them. But let me give you some reasons to explain the importance of this topic. It goes beyond this short-term target of exam, because if you understand this topic well, if you grasp this topic well and use this knowledge in your clinical practice, your ability to differentiate different types of glaucoma will improve, and you'll be able to give diagnosis to each and every patient of glaucoma. You will be able to save an eye going to blindness, because you will be able to pick up risk factors which are causing that progression. You will be able to improve the systemic health of a patient, because there are many systemic associations which you will treat, and the patient's systemic health will improve. Finally, you can actually save a life by actually doing a proper workup, and who knows, you might diagnose a neurological tumor there, and you might save patient's life. So let me start with this couple of examples. This is a 39-year-old lady who had a IOP normal range with a history of migraine. So you can see the optic disc in the right eye was essentially normal, but in the left eye you can see that there was a very early notch, a focal area of loss with the RNFL defect, and in the right eye visual fields were normal, left eye showed the inferior defect. Another example, 65-year-old gentleman came for a opinion. He underwent cataract surgery elsewhere, and the operating surgeon actually referred the patient to the neurologist, and came to me for an opinion. And you can see the optic disc. So right eye was significantly excavated disc, and the left eye had an inferior rim loss along with the RNFL defect. And this was the visual field. You can see significant field defect in the right eye as well as in the left eye. So in the normal scenario, we would label this patients as normal tension glaucoma. The question is whether to treat or not to treat, what investigation you will do, whether neuroimaging is must, what kind of follow-up protocol you will do. So hopefully during the end of our presentation, we will have answers to all these questions. So what is normal tension glaucoma? So normal tension glaucoma is essentially a progressive optic neuropathy where the IOP falls within statistically normal range, that is 2 standard deviations from the population mean. Ravi just explained more than 2 standard deviations. This is less than 2 standard deviations. So anything which is less than 2 standard deviation will be considered as normal tension glaucoma if it is associated with a progressive optic neuropathy. This is very important to understand. Now, what makes normal tension glaucoma unique? Now, we are all aware that in medicine parlance, when you don't know anything, you label it conveniently as idiopathic. Similarly, in glaucoma, it's a very common tendency and habit that you see a patient with a normal pressure and you see some cupping and you just diagnose this patient as a normal tension glaucoma. I call this as a diagnosis of convenience. Second point is that 50% of the patients that you diagnose as NTG will never progress, and fraction of the patients who are on adequate treatment may still progress. So even adequate treatment may not suffice. That's the reason why it is very unique. Now, why does this happen? It's because we still don't know whether NTG is a variant of primary open angle glaucoma or it is a manifestation of various ocular and cystic conditions. If you look at the prevalence of NTG, we need to understand this, that NTG is a part of primary open angle glaucoma as of now, today's literature. So when you look at primary open-angle glaucoma, it's a prevalence is around 1 to 4%. Out of that, you see more than 50% of the patients have actually normal tensions. In fact, a study from Japan showed almost 92% patients of primary open-angle glaucoma were actually normal tension glaucoma. Now, in order to actually do an effective management, it's very important to understand pathology and etiology of this condition. It's a very controversial topic, but unless you understand this, you will not really be able to investigate and treat. So essentially, there are two important points here. One is an IP dependent mechanism, second is an IP independent mechanism. Now, in normal tension glaucoma, even though the IOP remains in the normal range, it can still induce damage to the optic nerve. Now, this has been proven by this landmark trial called as collaborative normal tension glaucoma trial, where they've actually divided normal tension glaucomas into two arms: the treatment arm where they reduced the pressure by 30%, and the observation arm where they did not do anything. So treatment arm actually showed reduction in the progression of the visual field loss. So one thing was clear that IOP reduction helps. That means IOP was one of the factors in causing damage. Another concept that is now gaining importance is this concept of translaminar pressure. Here, essentially, we all know there is something called as lamina cribrosa through which our axons actually pass. So across the lamina cribrosa pressure, there are essentially two pressures. One is coming from the eye, and the other is coming from the CSF. So these pressures create a gradient. So if normally what happens is IOP is slightly higher than the CSF pressure. Now, if this difference increases, for example, if it's a high pressure glaucoma, the difference will be very high. It will cause direct mechanical damage to the lamina cribrosa and it will cause cupping. In normal tension glaucoma, what happens is the IOP is normal, but studies have shown that CSF pressure is actually little low. So there is resultant pressure effect on the lamina cribrosa, which is responsible for mechanical damage. Now coming to the IOP independent mechanisms. Now this is something that we need to understand even more deeply. So what makes this optic disc susceptible to intraocular through a normal intraocular pressure is something which has been actively looked into. So this is a topic of research. One thing that has come out is that these eyes tend to have thinner lamina cribrosa and a thinner prelaminar tissue. So that might make it susceptible for biomechanical or structural damage. Vascular factors, they are probably the most important etiological factor in glaucoma. To revise a little bit, so what happens in vascular factors is either there is a reduction in the ocular perfusion pressure, or the blood vessels have a vasospasm along with vascular decirculation. So it causes what is called as reduced ocular blood flow and altered levels of oxygen to the tissue, and that can cause either ischemic damage or oxidative damage. Now, this concept of vascular dysregulation is something which is key to understanding NTG. So what is vascular dysregulation? For that, we need to understand what is autoregulation. Now, autoregulation is essentially ability of the tissue to maintain its blood flow in spite of fall of perfusion pressure. Thus, in conditions where autoregulation is compromised, you will have a direct impact on the blood flow. In our context, it is the ocular blood flow. NTG is essentially associated with different forms of dysregulation, of which one is primary vascular dysregulation, second is secondary vascular dysregulation, which is associated with different autoimmune conditions, and then there is a third category of migraine and Raynaud's. But what is common between all these conditions is something called as an endothelial cell dysfunction. So there you have increased endothelial 1 levels, which is what is responsible for vasospasm and subsequently this vascular injury. Now, Flemmer's syndrome is a relatively newer condition which has been described. It is essentially comprises of clinical features that happen due to dysregulation of blood supply, which happens because of specific stimuli like cold, emotional stress, and hypoxia. And they are conglomeration of specific symptoms like cold hand and feet, low body index, arterial hypotension. Then they have difficulty to fall asleep and so on. So this is a very important concept to remember. Next is blood pressure. Now, we all know blood pressure is important because it's the driving force to maintain the ocular blood flow. Now, and it's a known fact that at night the blood pressure actually decreases. So a 10 to 20% dip is considered as physiological. So whether anything beyond 10% can cause decrease in ocular blood flow, this study which I am just highlighting, it has shown that. So they basically categorize patients into 3 groups. One is non-dipper, where the change of pressure was less than 10% at night. Physiological dippers, where the pressure was between 10 to 20% of the daytime BP. and over dippers when the pressure actually reduced more than 20% in the night. So you can clearly see that the visual field loss was much higher in the over dippers compared to non dippers and physiological dippers. So low blood pressure means there will be low ocular blood flow. That means it will lead to damage to the optic nerve. Then there are certain systemic diseases like obstructive sleep apnea, where combination of mechanical and vascular factors can cause optic nerve injury. A very simple tool is available called a stop bank. Is a questionnaire which you can ask the patient, and if you and this will help you to decide whether you would want to investigate them further for obstructive sleep apnea. Now, obstructive sleep apnea is a condition which happens because of partial or interrupted normal breathing due to functional collapse of the upper airway that leads to apnea and hypoxia at night. So these are intermittent episodes, and they induce increased sympathetic activity and vasoconstriction. Another concept is there which is called as impaired CSF circulation. Now, CSF circulation has a very important role in nutrient delivery and clearance of metabolic waste. And accumulation of, if it is hampered, it will lead to accumulation of toxic compounds, and that will lead to death of RGCs. Optic nerve canal in NTG patients have found to be narrower. That may be one of the reasons for this. Alzheimer disease is another association, and there the stagnation of CSF have been found to CSF stagnation is one of the things that has been found in Alzheimer's. So, having understood the etiology, pathology, and pathogenesis, when we come to a clinical evaluation, you should have three broad categorization in your mind when you see a patient. So, you need to first differentiate it from other forms of glaucoma. You need to differentiate it from optic neuropathy, and you need to look for non-IOP dependent factor. So, if you categorize these three things, you will not miss anything. So, first thing is the history. So, when you talk about history, you need to ask patients specifically if there is a history of pain and decrease in vision. So it can have, or certain things which can just cause intermittent rise of IOP without causing any symptoms. So these are the lists. So you can get it in intermittent angle closure, history of intermittent steroid use, specific yoga postures. Some people have a habit of taking large water intake. Then certain Valsalva maneuvers like conch blowing and playing wind instruments can all give rise to intermittent rise of IOP. Then sometimes you can have single event that can be there that can cause hemodynamic shock, for example, in blood loss, or trauma, which can cause hyphema, and the pressures may be elevated for a month or so, and then ultimately it settles down, and that's the time when the damage happens. Then you need to look at non-IOP risk factors, which we had just discussed. So you need to look for history of headaches, for migraine, blood pressure record, history of use of antihypertensive. When is the dosage taken? So if it's a nighttime dosage, that may be one of the reasons. History of snoring and all the symptoms that we discussed about Flemmer's syndrome. Neurological, yes, you need to ask them about antituberculous treatment. You need to ask them specifically for any SOL treated or patient is under treatment. You have patients who have had SOL removed about 25 years back, and subsequently 10 years down the line they underwent perimetry and they found some defect and they're on treatment. So this has happened with one of my patients actually. So this history is very important. Coming to the examination part also needs some time. So you basically, when you evaluate this, you need to look at vision, color vision, pupil, because that might give you clues to the neurological condition. Careful slit lamp examination will help you to give clues for pseudoexfoliation, pigment dispersion, trauma, etc. Gonioscopy is very important. We need to have the angle has to be open. We need to rule out that there is no pigment dispersion there. There is something called as a burn stage of pigment dispersion glaucoma, and that happens when the patient actually from a high pressure has become now normal pressure, and a classical sign that is seen in that is called as a pigment reversal sign. So normally what happens in pigment dispersion, you get more pigments in the inferior angle. In the pigment reversal sign, you get pigments more in the superior angle. So that may be an indication of burnt out optic neuropathy. Coming to the disc examination, you would look for focal defects or focal notches that are more common than primary open angle glaucoma, and you will look for disc hemorrhage. Disc hemorrhage is the most important finding which will give you a clue towards normal tension glaucoma. And when you talk about disc hemorrhage, these are basically present in prelamellar areas and superficial nerve fiber layer. They are usually, and any hemorrhage which is within one disc diameter from the disc margin can also be taken as disc hemorrhage. Exact cause we don't know, but it can happen in 1% of normal population. But if you look at NTG population, it is definitely much more in NTG population compared to even a normal primary open angle glaucoma population. It usually clears in 11 weeks. A point very important to understand this is then when it is clearing, it is very difficult to pick up. So you need to look at this sign very carefully. And recurrent disc hemorrhage is very important, because that when you document it, if it's a recurrent hemorrhage, that means the condition is not at all under control. CCT is important because yeah, if a patient is having a pressure of 20 with a CCT of 460, so we are not dealing with the NTG. It's basically, if you correct it for CCT, it becomes a primary open angle glaucoma. So CCT is important. HVF, OCT, and disc quota is important for documentation and further progression. We need to differentiate it from various other forms of optic neuropathy. I will not go to details, but you can do certain blood tests and other things to rule out those things. Now, this brings me to another important concept of neuroimaging. So, there are many instances, both in literature, even in routine clinical settings, where many patients have had compressive optic neuropathy and they have been treated as NTG, and even surgeries have been done for glaucoma, but they were actually patients having some or the other lesion in the neurology. But should we do neuroimaging in all patients with NTG? Actually, studies have shown that doing neuroimaging in all patients may not be so cost effective, and yield actually may be low. So you need to look at certain atypical features like, lower levels of visual acuity, neuroretinal pallor, poor correlation of pattern of visual field loss versus and optic disc cupping, and a vertically aligned gland. Just to share you a very interesting example, this patient came to me for a second opinion. He's a 82-year-old gentleman with IOP of just 12 millimeters. And if you look at his visual fields, 2007, his visual field was like this. He was started on treatment, and he was, and then every few years they would repeat the visual field and add one more medication. So now you can clearly see that there is a temporal defect which is expanding the midline, and all we had to do was a neuroimaging, and it turned out to be a pituitary adenoma. So you have to keep your eyes open, see where the defect is. If it is in the atypical quadrant, or if it is respecting the vertical midline, you need to investigate. So look, the last thing probably would be to look for non-IOP dependent factors. If nothing else, you're able to get it. If the condition is still progressing in spite of treatment, then probably a 24-hour BP record, a sleep study, nail fold capilloscopy, and color Doppler imaging to assess the ocular blood flow can be undertaken. I'm not going to go in details of this. Just to show you how a 24-hour BP record can be helpful. This is from one of my patients. You can see this patient was progressing in spite of the best of treatment. You see how much the IOP was fluctuating in 24 hours. Systolic fluctuating from 168 to 102, and diastolic from 71 to 41. So there's a huge drop at night, and that can cause reduction in the blood flow, ocular blood flow. Carotid Doppler definitely can be undertaken, because some patients can have significant flow obstruction, which can give rise to optic nerve damage. Now, coming to how do you manage these patients? So again, you need to take the clue from this study, which tells us three important things: that 50% of your patients will never progress. In patients who are progressing, treatment will definitely help, and some patients will progress faster. And these being female patients from female sex, history of migraine, and presence of disc hemorrhages. But you understand one thing: you can still observe some patients, like patients having just mild visual field defect, no risk factors for progression, and you follow up to see whether they are progressors or non-progressors. So IOP lowering treatment definitely is needed in some in a group, and you aim for 30% reduction, and you can use any of these. Choice of treatment would be prostaglandin analog, because they have the best IOP lowering capabilities, and they have a very good nocturnal IOP control. In fact, latanoprost has been shown to have some kind of neuroprotection also. Now, I'd like to also highlight this study, which is a recent study, which essentially compares brimonidine with timolol, and what they found out was that IOP reduction, both the groups were similar, but there was less progression in the brimonidine group. Now, why did this happen? Now, this difference due to additional neuroprotective effect of the brimonidine, or was it the detrimental vascular effect of the timolol? The answer is unclear, but this clearly shows that IOP reduction is not enough. So in short, you have to avoid beta blocker, because their IOP reduction in nighttime is anyway less, because nighttime aqueous secretion reduces, so it will not make too much of a difference, and they have a direct effect on the blood pressure that can cause reduction in the ocular perfusion pressure. Alpha agonists, yes, because they act in two ways: decreases the aqueous production and increases UV scleral outflow. They also, in animal studies, have shown to have neuroprotection effect. Carbonic anhydrase inhibitors, they have been shown to have definitely a good amount of increase in ocular blood flow, and they cause dazolamide has actually been shown to cause some amount to give some amount of neuroprotection. Surgery may be needed if there is if nothing is working, but you can aim to bring IOP in the single digits also. Since a lot of systemic factors are there, you would probably need to do some bit of lifestyle modification, like you need to ask the patient to stop smoking, regular exercises should be done, avoid certain yoga exercises and breath holding maneuvers that patient must be doing. Lateral cubitus position can be avoided. And something which has come up recently is to avoid smartphone in patients who are around 20 to 40-year-olds, young patients with NTG, because it has been shown that anything more than 25 minutes of smartphone use can cause increase in IOP, which is more than normal patients. So in short, this is the flowchart how you will approach. So first thing, you will make sure that you have ruled out all the other forms of glaucoma, and you have done a diurnal which shows that it's a normal range for IOP. You see that there is a disc suspicion, you do a visual fields and OCT, and if it comes out to be normal, just put the patient as normal tension suspect, establish a baseline data, follow up and look for a change. If you find it is abnormal, the next thing is that you have to rule out a neurological cause, understanding the risk factors that we discussed. And if that is ruled out, then it's a confirmed NTG, establish a baseline data. You can observe them or you can treat them. Treatment, look for progression. If it progresses, then you investigate for risk factors. So coming back to our two cases, so this lady who was having a little bit of defect here, we decided to observe, and it's been 4 years, she has not shown any progression. This gentleman, actually, when we investigated him further, he did give history of snoring. We did a sleep study for him, and it turned out to be a severe form of obstructive sleep apnea. So he was on anti-glaucoma medication along with CPAP treatment. This actually improved his quality of life because the oxygenation levels improved. So to conclude, I would say that normal tension glaucoma is an enigma because we still don't know whether it's a one-time damage, because under 50% of patients will not progress, whether it's a POAG variant because some patients will still do respond to IOP lowering, whether it's a neurodegenerative condition because of its association with Alzheimer's, or whether it's an optic nerve disease in a sick body, say patients with vascular dysregulation, or it's a disease optic nerve in toxic CSF environment. So studies are going on. In fact, it is one of the most researched topic in glaucoma, very controversial. But what you need to understand is that you individualize your patient and give them treatment based on whatever clinical findings you have. Thank you for your kind attention. Thank you.